We are we are physicists who deal with um, radiation in medicine. There's like three different tracks you can go. There's the nuclear medicine side for like PET imaging, uh, diagnostic, which kind of covers CT, MR, ultrasound, any sort of medical imaging. And then what I am focused on is the therapeutic side. So that's radiation that's being used for cancer treatments.
Ooh, I know somebody who's doing that.
Yeah.
Appreciate it. And Ben reached out, which is very, very cool. And I appreciate this. So we're not going to ask him any medical advice, but we want to understand, you know, back in that control room, and I think what I'm having is called tomotherapy. Does that sound right?
Yeah.
Okay. Back in that control room, is it like a microwave? And at some point they're going like pizza or papa or just, you know,
It's the control room is it's mostly just like this one little board with buttons that light up, and they get your imaging lined up to where they know your treatment is going to be accurate, and then they just go boop, and
yeah.
it just does its thing. And
Well,
they
this is
they
probably
watch you on the cameras and make sure you're holding nice and still, because if you
yeah.
moved out of the way, we would be treating you in the wrong spot. So
Well, yeah, I want to come to that in a minute. So just to give everybody the other steps, and this will be fast. You arrive in the morning, you scan your card. That way you're identifying it's you who's in line in the queue to be treated. And then somebody comes to get you because the timing can be off. You know, it's kind of a floating schedule for patients arriving. But if somebody's having fluid issues or whatever, everything has to move. But so when it's your time to go, you know, into the slab, you scan it in again. And if I understand correctly, that's identifying the program, the therapy that I'm having so that it doesn't have to be, you know, manually looked up every time. Is that what's going on?
um, there are a number of like automated check-in systems that people use. There's two main vendors for like the software that controls patient information and everything, but then uh, it sounds like you have some badge that scans and it checks you in and tells that software that you're here and you're ready to be treated. And then the therapist will see that there's a little icon next to your name, so they know that you're here and waiting. And then there must be another spot that you scan your card that actually pulls your plan up and makes sure that like this is you, this is your plan, everything matches, so we don't treat someone with someone else's
Right.
information.
Yeah. So uh, I'm having, and I've talked about this publicly, so it's all fine to a point, I guess. Uh, I'm having prostate bed radiation to eliminate because after my surgeries and you know and the other medicines and stuff, the my PSA started rising again, and it was rising. You know, it wasn't big; it was very small, but it was rising relatively rapidly. You know, for somebody who'd already had you know the
Sure, yeah.
me. So I understand this is normal, a normal process for that. So now I come because in a situation, oh, and they said there also wasn't one lymph node that needed to be hit. So I come in for a simulation, is what they call it, to get, which I guess is where you come in. Are you involved in that, or are they following a routine?
Um,
Explain
so
what simulation is in the process.
a simulation is we some places call it a mapping simulation. It's we take a CT of your pelvic area, and that's going to the doctor will designate where exactly he wants to treat. So he'll contour what we call the targets, which in your case is the prostate bed and maybe lymph node chains that goes up your pelvic region. And he says, this is the area I want to treat, and this is the dose I want to treat it. And that CT, someone called a dosimetrist, who makes the plans for everybody, they will create the plan on that CT, and that is your baseline truth. Like this is what we want your setup to look like every day. So when they had you do your simulation, they probably had you drink a very specific amount of water, make sure you didn't eat beforehand, so that your bladder and rectal filling is going to be consistent every day, because we're going to be shaping the dose around. So like if you were to look at a slice of your CT, your prostate bed's here, you've got your bladder up here and your rectum down below it. So we kind of shape the dose around it so that your bladder and rectum isn't getting too much of the of radiation. So it's important that your everyday bladder and rectal filling matches that simulation as closely as possible.
So 2 weeks into this, I just have my 14th treatment today. Uh, that's harder than you think it is. My whole,
Yeah,
well,
I
you
am
know,
sure.
yeah, because as some scarring occurs, which has happened with me, you start to get some stomach issues, which messes with the bowel patterns and all that. And so then
Hmm.
you tend to get dehydrated. You can drink a lot of water. I'm going to stop complaining in a minute, but this is for anybody who goes through this. And so you've got to have, my number is 128 when they do the ultrasound to see how much is in the bladder. And I've had it be 500. I've also had it be 50 something. And it seems like all drinking the same amount of water consistently every day.
Yeah.
It just feels like you're rolling the dice when you go in, like, so how am I? And they go, you watch their faces for the disappointment, which yeah, slows things down.
Yeah.
So I guess having rambled on about that, my question is that those minor amounts, if your bladder is at 100 or your bladder is at 400, how much does that actually move the organs, that you guys are targeting?
Um, so every patient's different. And with a prostate bed, since there's no prostate there anymore, if there was a prostate, the bladder filling will push it a little bit, but it can only push it so much because it's kind of rooted in place. But with a prostate bed, your bladder kind of like fills into that space some more. So that might be why they're being more accurate with it. At my center, we don't use a ultrasound to test or anything. We just, when you're on the table, they do a shorter scan to align your anatomy from today up to the anatomy from simulation. And for us, we turn on the bladder and rectum overlays. And if it looks like it's pushing too far, or, when the bladder fills up, the prostate might tip a little bit. And if it's tipping too much and it doesn't look like it's all going to be within the contoured volume that the physician wanting to treat, then that's when we'll get the patient off the table and say, we need you to drink a little bit more water, or it looks like you've got some gas in your rectum. You might need to empty your bowels out and then kind of start the process over again.
Okay, so from a patient standpoint, that's new information to me. I wondered that the question I asked you was legit, one that I've had, and you're the right person to ask it to. So that's all. Uh, but once, in my case, I go in and I'm on the table, they give you a modesty towel and you can drop trowel just a little bit, kind of get ready. And then I've got the little tattoos to line up the lasers on my hips, my belly.
Hmm.
So they do all that. Then they don't. They do the ultrasound first. That's right. They do the ultrasound, and if the ultrasound is okay, then they get you lined up, and then they leave the room and they start the thing. But you go into the machine for a couple of minutes, and I assume that's when the process you just talked about, Ben, is taking place, where they're looking at, so they could see that. That's good.
Yeah, yeah. So Tomo is a little different. It's not the most common machine out there. It's a specific vendor of machine. So it looks more like a CT scan. So as you're laying in there, it will quickly spin around you once and create this CT for today's anatomy. And that's where today's and the simulation gets overlaid on top of each other. And they'll look at your bladder shape and your rectum shape today and make sure that it's within our tolerances to know that we're not going to be overdosing your normal tissue.
Okay.
So yeah, they do look at the image for today, and then typically you'll just be laying there wondering, like, did they forget about me? It'll take a couple minutes for them to like line everything up and make sure that it looks exactly the way we want it to before we turn the radiation on.
It's a good point. That's been the most everything else you can kind of time what's going to happen. That part does you can't tell. Sometimes it
Yeah.
okay, that
Yeah.
helps.
And then sometimes if you have gas in your rectum and it's pushing up a little bit, they might call the physician over to take a look at the images and give the okay for today. And anytime you have to find a physician to come look at images, it could take several minutes because they might be talking to another patient somewhere.
Yeah. Oh, that's interesting. Okay, so now let's get down to uh, turning on the microwave. So it sounds like I described the process as, when you could tell when they're starting the thing up because they're kind of a popping popcorn, and that happens while you're out. You'll hear, and then they move you in, and then over time it starts to cycle up. And so what the patient is hearing is that, you know, kind of just rattly sound, and you get a sense that something is spinning around you. So what's happening, Mr. Physicist?
Uh, I'm not super familiar with tomotherapy because that's a machine that we don't have, but it is similar to a CT. There is something that's spinning around you while the beam is on. So it needs to be spinning at a constant speed. So it takes a minute to ramp up speed first, and then the rattling sound. They're the beam shaping devices that are um, molding the radiation to the exact shape of the tumor that we're treating.
Those are
They're
things.
Yeah, I have a lot of visual aids here. Wait, let me go grab one real quick.
Yeah,
I
no
have it
worries.
right here. So these will be a little different than yours just because this is off of a different machine, but this is just a solid hunk of tungsten, and like it's got quite a bit of heft to it.
Okay.
But the machine has, I don't know how many Tomo has, but the other type of Linac that'll be more common for people getting treated, there's 120 of these,
Okay.
and they kind of like they're in opposing pairs and they move, and the radiation coming through it gets shaped by these things.
The
In
sound is those things physically,
in
tracking.
in tomotherapy, there's a bunch of them that I think they're just like either in or out, and they just like move very quickly. And when they're like clacking around, snapping into place, that's the sound you're hearing, I think.
Wow. So, I mean, are they, yeah, because of the density of the tungsten, is that capturing some of the radiation, and
Yeah.
the pattern
So
is being developed just by when the slits allow something.
yeah, for the case of a normal
Hmm.
linear accelerator, uh, there there's 120 of these that cover the entire field, and most of them will be blocked, like touching tip to tip like this, so that no radiation's coming through. And then they open up to form the radiation as the machine is rotating around you. So in your case, you can't see it, but in the other type of machine, as it rotates through, if your face is looking up at it, you can kind of see the leaves. What these are called are leaves.
Okay.
But you could see the leaves moving back and forth and shaping the beam as it's rotating around you.
So you talk about a beam of radiation. Can put a little more flesh on that.
Um, it's basically like a flashlight. It is just the same thing as light. It's just very high energy light. So it's produced in the linear accelerator. Electrons are coming through, and then as electrons stop, there's conservation of energy. So uh, electromagnetic waves get created as the electron stops. So basically, we're shooting a bunch of high energy electrons into a high density metal target. And as they stop, it's just making this flood of radiation come out the other side. And that's what we call the radiation beam.
And that is destroying cells.
Yes.
Did
It's
I put a negative word to you?
it's a very complicated process of it all, but the radiobiology of it is this is ionizing radiation. So it's higher energy enough that when it interacts with an atom, it kicks an electron off, and now that atom is ionized. So within a cell, uh, it's actually interacting with water, uh, yeah, water molecules, and then hydrogen fixes to the water, and you have a hydroxyl. And the hydroxyl is a free radical, so it's like it's very this is where my chemistry is lacking. I can't remember all these words, but the hydroxyl really wants to like bind with another because it's like it's an O and an H and is looking for another spot to bind to. So when it ionizes your DNA, also the hydroxyl will fix to the DNA, and that prevents your cell from repairing that damage that's done. So as the cell cycle goes through, as it's about
Yeah.
to go through
Yeah.
mitosis, then it sees that that DNA is damaged and it's unfixable, and the cell goes through apoptosis, what it's called. So the cell just basically dies. That's
There's a
a
I
very,
don't
very long-winded answer. The cells don't kind of just destroy themselves. It's DNA damage that's occurring, and then when it can't be repaired by the cell, that's when the cell kind of kills itself, basically.
What is the length of that process? If you could isolate one cell that got irradiated, what's the time frame for that?
I think it's typically uh, about 2 cycles per day. I know some treatments that we do are 2 fractions per day, and we need to make sure. Actually, it might be a little longer than that. My biology is not great. I took one class on radiation biology back in school, but we don't have to think about it too much. But for people that are getting 2 fractions per day, we do want them spaced out by 8 hours, and that's probably the length of a cycle to make sure that your
Oh,
first fraction of the day had its benefit before you're getting the next fraction of the day. You don't want them to overlap because that would mess up the fractionation and prescription and everything.
gotcha. This one's personal, but I haven't, I see, obviously I'm making friends in the
Yeah.
onc on a regular, and I've got my captors. There's a little Stockholm syndrome going on, I think.
Yeah.
Don't touch the machine because I might do any of those at any time. Yeah. So this one's personal. I've and met a lot of people. I haven't talked to anybody else who has as many scheduled as I do. I have 36 radiation treatments spread. That's takes a lot of time. Not really complaining if it's the right thing to do. But how is that determined? Why am I not having? I'm not asking for you to know exactly, but why would one be in that situation as opposed to 18 smaller
It's
size or some other?
it's really just over the years they've done all these studies on different prescription regimens for different types of cancers, and it's just that different cancers respond better to different amounts and numbers of fractions of radiation. So for prostate, based on the staging and type of cancer you get, there's uh, you can get up to 43 treatments, and then there's kind of a mid range of like 26, and then there's the much higher dose per fraction. You might get just 5 treatments. It's kind of all
Wow.
over the board with prostates, and then prostate bed's a little different because we're not treating the actual prostate. So in your case, you're getting 30, forget what you said, 36 or 37.
Which of
And
all
then
the Asian treatments I've ever had is just a number. I have no idea if that's the right or wrong. You know, yeah,
yeah,
trust
and
me.
I mean, even if you talk to different doctors, everyone has their own opinion on which studies have come out that they base all their treatments based on. Yeah, prostates though typically have the most. Breast will typically be anywhere from like 16 to 25, 30 treatments. Head and necks are usually 30, 35, and then lung is somewhere around 30, 33 as well. So
Interesting.
those are kind of like the time frame of it. But then there's also the higher dose ones for early stage, like if you have a tiny little met that was caught in a lung screening scan or something. A lot of the early stage stuff is typically treated in like 5 fractions or less.
Okay. Oh man, there's so much more I'd like to ask you, but it would go on. It's probably already too long. Uh, your whole family is amazing, Ben. Thank you for doing
No
that.
problem.
And I'm going to be teaching. I asked Ben a tune that he wrote called "Contributing to the Delinquency of
A minor.
A Minor." Yes, contributing to the delinquency of A Minor. It's a cool tune. It's a grooving thing. So I'm gonna perform that and share some of that stuff coming up soon.
Nice.
You getting to play any?
I haven't really. I'm planning on going back to Everett this year. I was at Everett last year, but that's really the only time I ever play the dulcimer. Even when I was back in Michigan, I don't really enjoy playing it by myself too much. I like playing in a group of people,
Yeah,
and I
yeah.
haven't sought out. I'm sure there's people out here that play, but I haven't sought it out yet.
I suspect the different times in life, or when you get to do things, right?
Yeah,
All right. Well, thanks so much, Ben.
no
Give
problem.
your family and hope to see you in Everett, not this year, but maybe in a year or two again. All right.
Awesome. Sounds good.
Bye.
Bye.